Hello there. Hello. My name is Valentina Bue, and I'm currently revising for exams and going through all these summary sheets that I made back in the day when I was putting in effort. I kind of dropped out of doing these, or dropped off from doing these. But I'm going to revise this and I'm going to take you on the journey with me because I feel like being a YouTuber today. Anyway, so we're starting off with malaria today. Da 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 da. So malaria is a protozoan-borne infection, and it's transmitted by the female Anopheles mosquito. The protozoa takes on a bunch of different forms as it evolves. So it's important to know its life cycle because it kind of ducks in and out of multiple creatures and multiple cells in the body. And the reason we want to know this is because different drugs target the plasmodium or the protozoa at different sites or different phases in the life cycle. So imagine we got this little mosquito here. She's bitten someone, queen, and now she's got what is called a sporozoite in her. So sporozoites inside the mosquito undergo sexual replication and development in the salivary glands of the mosquito. So obviously when they then bite someone, they're going to deliver these sporozoites into the bloodstream of their next victim. So these sporozoites travel through the bloodstream to the liver, where they enter the exoerythrocytic stage, or the liver stage, as we like to see it. So once they get to the liver, they basically enter our hepatocytes, or our liver cells, where they undergo asexual multiplication to form what's called schizonts, which are filled with merozoites. So they're having a merry time in the liver. And so once these merozoites have replicated to their satisfaction, what happens is that they are released into the bloodstream where they mature into trophozoites, which are these little guys here. So trophozoites then have the capacity to enter... Oh, you know what? I take it back. Merozoites enter red blood cells and mature into trophozoites. And once the trophozoites have eaten up all the hemoglobin that the red blood cells have to offer and have replicated as much as they like, they cause the formation of schizonts, again, which are groups of these plasmodium. And this causes the rupture or hemolysis of the red blood cells into the bloodstream again. So now, these merozoites, which have been released again into the bloodstream, can differentiate into gametocytes, or the kind of sexual form of the plasmodium. And they can travel and be sequestered into the bone marrow, and they can then enter the blood again once they've finished differentiating, which is usually the form that they are ingested by mosquitoes in. And so here, in the mosquitoes, they mature in the intestines. So the gametocytes turn into sporozoites in the intestines. Then they travel to the salivary glands again, where they start sexually replicating, and the cycle starts again and again. So that is our malaria life cycle right there. And the way that I remember this, in terms of the order that things happen in, is this mnemonic of so many titty sucking girls. Sporozoites, merozoites, trophozoites, schizonts, gametocytes. I hope that helps. Alright, now I'm going to zoom in on this part, the exoerythrocytic stage, which can involve the liver. So there are two types of Plasmodium that can actually form hypnozoites in the liver, which is the dormant form of the Plasmodium. So when they've formed or achieved dormancy in the liver, what can happen is they can kind of reside there in the liver for years, for months, for weeks, and then they can reactivate, causing a relapse. So someone might think they're cured from malaria, and then suddenly, boom, they've got fever, they're vomiting, they're nauseous, they're jaundiced. And it turns out that they had Plasmodium ovale or vivax. So that's the importance of kind of the liver stage. So taking us back, you're like, oh, Plasmodium vivax and ovale, how dare they have more than one form? Well, joke's on you, there's actually 5 forms. I think there's actually more than 5, but 5 is the number that we actually need to know about for our Notre Dame exams. So basically, the most important form, and the form that I basically outlined the life cycle of previously, is Plasmodium falciparum. So Plasmodium falciparum is the most severe form of malaria. And basically, if you get falciparum, you're either cured or you die. You don't just have it, you know. It doesn't just, you know, exist at a low level in you. It's pretty bad. So Plasmodium falciparum is found mostly in sub-Saharan Africa. Another form is Plasmodium knowlesi, which is also severe and mostly found in Malaysia. And then we've got our 2 types of Plasmodium that can form dormancy in the liver, ovale and vivax. Here it's important to note that Plasmodium ovale actually has a moderate severity, whereas vivax can be considered as almost benign. But yes, they can form hypnozoites, which are those dormant liver forms of the Plasmodium. And finally, we've also got Plasmodium malariae. Just benign. I'm sure there's a reason to care about him, but we can move on. Anyway, okay. So someone comes in, they're looking a bit wild, they're looking a bit, you know, jaundiced, and we gotta diagnose them with malaria. So what are we gonna do? Actually, you know what? I take it back. We're gonna go to the pathophysiology of malaria. So yes, we've got stuff happening in our bloodstream. We've got little itty-bitty bobs that are traveling around, but what is so bad about them, you may ask? Well, let me tell you. So one of the reasons that Plasmodium falciparum causes such severe consequences and symptoms is because of its ability to sequester red blood cells away into the microvasculature of the body. So Plasmodium falciparum, once it infects red blood cells, it causes the expression of this little protein called Plasmodium falciparum erythrocyte membrane protein 1, or PFEMP1. And what this protein does is that it causes red blood cells to stick to each other, forming what are called rosettes. So rosettes are now, say, much bigger than your average sized RBC. And now what can happen with these rosettes is that they can stick to each other and to the walls of endothelium, and therefore they can get sequestered or stuck in microvasculature of the body. And if you think about places that have microvasculature, you're thinking of the places like the brain, the spleen, the kidneys. Oh, they're not in this photo, and that's going to create some of the clinical features that we'll see. So starting off with cerebral malaria. Cerebral malaria, which is common or a consequence of Plasmodium falciparum infection, is where sequestration of infected erythrocytes in the brain microvasculature leads to hemorrhages and infarcts, because obviously if you've got plugged up blood vessels, you're not getting blood to the brain, you're going to get ischemia, and this leads to neurological consequences such as confusion, convulsions, seizures, and coma. So that's one of the reasons that Plasmodium falciparum is especially bad. You're also going to see things like splenomegaly due to increased hemolysis or destruction of red blood cells, and vascular congestion, again due to this rosette formation. You might also see renal dysfunction, again due to microcirculation disturbance caused by rosettes. Oops, I forgot an E. Okay, so those are 3 things that can happen. Other things that might happen are, actually I'm going to go to this part. So imagine you've got these yucky red blood cells, they're ruptured, they're going everywhere. They're going to travel through the spleen, and the spleen's going to recognize them as dysfunctional. And so what's going to happen is they're going to get hemolyzed or undergo hemolysis and the breakdown of red blood cells. And this, in addition to the fact that hemolysis is actually part of the life cycle, leads to an excess of bilirubin in the blood. So this leads to jaundice. You're also going to get things, respiratory symptoms such as respiratory distress, cough, and pulmonary edema. You'll get hepatomegaly due to vascular congestion, again from rosettes. Damage to hepatocytes due to rupture during the release of merozoites into the bloodstream. You're going to get a hemozoin-stained liver. You can also get hypoglycemia due to the failure of hepatic gluconeogenesis, so that's more secondary to the hepatic dysfunction. And you will get, very importantly, what are known as fever paroxysms. So fever paroxysms refers to the cyclical nature of the fevers that you get in malaria. So you might be infected with Plasmodium falciparum and have a really high temperature, and then a couple of hours later, 24 hours later, you actually feel better and your temperature's gone back down to normal. And then after that 24 hours, your temperature goes back up and it goes back down, and it kind of cycles. And that's what's known as a paroxysm. So the reason for these paroxysms is that the fevers are associated with the rupture of these red blood cells, leading to an increase in pro-inflammatory molecules such as TNF-alpha, which is a cytokine. So the waves of the fever correspond to the reproductive cycle of the Plasmodium. So again, we've got our life cycle here, and every single time we get to this stage where our erythrocytes are rupturing, we're going to get an increase in those pro-inflammatory cytokines, leading to a fever. But the fever will kind of chill out around here and then come back around here, and that's where we're getting those fever paroxysms. Other GIT symptoms include nausea, vomiting, diarrhea, abdo pain, and anorexia. Okay. Oh, yes. Sorry, malaria is so extensive, jeez. Okay. So, another very important aspect of malaria, or symptom of malaria, is anemia. So, due to the presence of misshaped red blood cells and increased hemolysis, as well as the fact that malaria parasites are feeding on the hemoglobin in your red blood cells, you're going to get an overall decrease in hemoglobin, leading to anormocytic hypochromic anemia. And of course in your bone marrow, which is where your red blood cells are being made, the decrease in red blood cells is going to lead to an increase in EPO, and that's going to lead to increased erythropoiesis, or formation of red blood cells, and that means there's going to be an associated decrease in the formation of platelets, leading to thrombocytopenia, and a decrease in formation of white blood cells, leading to leukopenia. And as we know, thrombocytopenia can lead to coagulopathies due to clotting disorders, as we need platelets for clotting, and leukopenia can lead to increased risk of infection, as we need white blood cells for fighting infection. Alright, now to go back over here. Imagine we've got someone, and now we understand that their symptoms are pointing to malaria. How are we going to diagnose that? Well, what we're going to do is we're going to take their blood, we're going to smear it on 2 separate light microscopy slides. You're going to make a thick film and a thin film. The technique is kind of self-explanatory. And you're going to have a look at them under the microscope. So, on a thick film, what you're going to use it for is basically to see whether or not you're right, whether or not that person actually does have malaria, because you'll see the plasmodium under the thick film. In contrast, a thin blood film, which is the one that's shown here, is used to subtype the type of plasmodium, because each plasmodium, and I didn't include I've heard of every one of them, but they all look very different. Each one will look different on a thin blood film. So here we have an example of Plasmodium falciparum, because that is the most severe one. What you're going to see are things like ring trophozoites and crescent-shaped gametocytes. And remember, trophozoites are the form that are found in the red blood cell, and gametocytes are the sexual form that are usually taken up by mosquitoes when they suck your blood. Okay, so now imagine you've gotten the thick and thin blood film, you've confirmed that someone has malaria. What are you going to do next? You're going to treat them. So in terms of the pharmacology of malaria, can be divided into kind of 2 phases. We can think of prophylaxis, and we can think of treatment. So before we go into the actual pharmacology of malaria, I'm going to just quickly highlight this process that goes on inside erythrocytes that have been infected with Plasmodium. So in erythrocytes, we have hemoglobin, which is made up of heme plus globin. The heme is ingested by the malaria pathogen, the Plasmodium, and converted to hemozoin by an enzyme called heme polymerase, which is only found in malaria. So, of course, because the malaria need the hemozoin to survive, it makes sense that heme polymerase, this enzyme, is the target of most of our pharmacological interventions against malaria. So starting off with, okay. How do we do this? Basically, there are a bunch of different drugs that target heme polymerase. We've got the classic, the historical, chloroquine. Chloroquine inhibits heme polymerase and historically has been used. However, there's been a really large development of resistance to chloroquine by a lot of Plasmodium. And so we've kind of moved on from that. I'll take you up here. So everything in purple is used to inhibit heme polymerase. Our classic treatment is for uncomplicated malaria is artemisinin combination treatment. So when they say artemisinin combination treatment, it refers to a bunch of things. But the example that I'm going to show you today is the example of artemether and lumefantrine. So both artemether and lumefantrine are heme polymerase inhibitors. Artemether is effective in against Plasmodium that's resistant to chloroquine, which is great because there's a lot of resistance. And lumefantrine, although it's got the same mechanism of action as artemether, it's been shown that when you use both of these together, it's much more effective at kind of curing people with Plasmodium infections. I've listed some of the adverse drug reactions here, which you can have a look at. However, I wanted to draw your attention to this bad boy right here. So artemether and lumefantrine are usually used for our classic types of malaria which do not have hypnozoites or do not have that dormant phase in the liver. Specifically, I'm referring to Plasmodium ovale vivax here. If it's been diagnosed through thin blood film, that a patient has Plasmodium ovale or Plasmodium vivax, you're going to add on this very special treatment to your ACT of primaquine. So primaquine is considered what's called a radical cure. A radical cure targets the the forms of the Plasmodium that are also dormant in the liver. However, it is important to note that you cannot give primaquine to a patient that has G6P deficiency, and similarly, you can't give it to pregnant women just in case you induce hemolytic disease of the newborn. So, no pregnancy for primaquine. Now, another treatment, or prophylaxis in this case, is quinine and doxycycline. So quinine, again, is a heme polymerase inhibitor, whereas doxycycline is a type of antibiotic. Quinine also is not allowed, you can't use it, or what do you call it, contraindicated in G6P deficiency. And its adverse drug reactions include something called kinchinism, where you can get GIT issues, tinnitus, hearing loss, and vertigo. What is this? HAs. I don't know. I wrote the same ages ago. And quinine can also be found in tonic water, and that's important to note because, say if you're in an area with few resources and limited access to pharmacological interventions, you can actually give someone tonic water containing quinine to help manage their symptoms and help kill off the malaria. Doxycycline, in terms of adverse drug reactions, it cannot be used in pregnancy and in kids less than 8 because it can cause teeth discoloration and enamel hypoplasia. And then finally, one other form of treatment and prophylaxis is atovaquone and proguanil, which don't have anything to do with heme polymerase, but they themselves prevent the function of the Plasmodium parasite. I could have been saying parasite this entire time, my gosh. So atovaquone inhibits nucleic acid and ATP synthesis, whereas proguanil is converted to its active form, cycloguanil, and this inhibits dihydrofolate reductase, which is required in DNA synthesis. So that is basically our pharmacology. I'll end the pharmacology by mentioning mefloquine. So mefloquine is a very, very effective drug. However, it has some pretty weird adverse drug reactions, namely anxiety, depression, insomnia, and vertigo. So these are all like psych symptoms or psyche ADRs, and so therefore it's usually kind of contraindicated in people who have neuropsychological issues such as seizures. Okay, all right. Last thing that I wanted to mention is sickle cell anemia. So sickle cell anemia is a genetic mutation that causes sickle-shaped red blood cells due to a deformity of the red blood cell membrane. It's important to note that sickle cell anemia is protective only in its heterozygous form. So say I use capital S for a normal red blood cell membrane gene, whereas a small s is a sickle cell red blood cell gene. If someone has if someone has one sickle cell gene and one normal gene, that means they'll have something called sickle cell trait. And this means that they have some cells that are sickled and some that are normal, and therefore they are protected against malaria for reasons that I'll outline in a bit. However, if someone has two sickle cell genes, so they're homozygous for the sickle cell mutation, this means that they can have the more severe form of sickle cell disease. And because your red blood cells are needed for like oxygen carrying, this can lead to severe disease, as well as the fact that sickle cells undergo more hemolysis. God, I don't even think that made sense. Anyway, alright, so there are 3 reasons why sickle cell anemia is protective against malaria. The first reason is that the sickle cell shape causes leakage of essential cell contents out of the red blood cell due to the increased porosity. And this is bad for the Plasmodium parasite because the parasite needs things like hemoglobin and other nutrients that are found inside a red blood cell in order to stay alive. So sickle cells lead to dying Plasmodium. A second reason is because sickled cells are usually detected by the spleen as abnormal and hemolyzed. So increased hemolysis of infected red blood cells is protective against malaria. And a third reason is because the morphology of sickle cells prevents their sequestration in the microvasculature. And this means that you get less things like cerebral malaria due to ischemia of the brain, and you also have those infected red blood cells not being able to hide away from the immune system, which leads to a better immune response against malaria. So those are our 3 reasons why sickle cell anemia is protective against malaria. And interestingly, that's why a lot of people in countries where malaria is endemic exhibit this sickle cell trait, because they've literally evolved to be resistant to malaria. Anyway, that is it from me. That was honestly chaotic, and I probably could have scripted that instead of just improvising it, but yes. Thank you for listening, and I would like to put a disclaimer that I am simply a clueless student. So if there was any incorrect information on here, I sincerely apologize, but hopefully this will help with revision in the future, mostly for future Val. Thank you, goodbye!